Ended with a fully occluding right ear canal. The earwax extended right from the entrance of the ear, as you can see here, right towards the eardrum. So it's quite a severe impaction. They were barely able to hear the suction machine today. This client actually attended today. Upon attending, the wax is quite glutinous, quite sticky. You can see there, I'm just trying to loosen it off the canal wall. So just posterior canal wall. So posterior means the back part of the ear canal. I'm now going to the roof of the ear canal. You can see where it attaches to the ear canal. There's a few skin adhesions. So this first piece of wax, it detach quite easily, but it is quite sticky, so on a few occasions you can see that it's blocked the zone, the suction probe. So I'm just wriggling it and it's unblocked. So again, I'm just going to the roof of the ear canal. I think this video really illustrates why endoscopic earwax removal using the iClearScope device that Clearwax developed is so advantageous. It's just a view that we achieve using an endoscope. You wouldn't achieve this view using any other visualization technique. So other methods of removing earwax include what we call head loops. It's similar to what dentists wear, and also an operating ENT microscope. So an operating ENT microscope provides magnificent magnification, but the field of view, you'll probably see about a fifth or a quarter of that eardrum or the ear canal. You won't see the whole ear canal, and I think when you remove wax, it's so important to be able to visualize the entire ear. So we know which parts to manipulate, where the ear canal exactly is, so we don't come in contact. And with an endoscope, you really do feel like you're inside, well, at least I do. I feel like I'm inside the ear and I'm looking all the way around me. So we just got a bit more wax, just impacted on the eardrum. It's just blocked my suction probe. I'm just wriggling it outside, but it's not unblocking. Oh no, it did unblock, so I've gone back in. And the wax is stuck in the anterior recess. You can see it's quite mushy, this part of this section of the wax. So I just had to come out, unblock the suction probe, but right on the eardrum here. And remember, we're really delicate when we're working this close in the ear canal. There's a tympanic membrane. You can see there's a bit of scar tissue, a bit of white scarring around the edge and the periphery. So that's what we call tympanosclerosis. This is client 2. So this client again attended today. I just thought, whilst they've attended today, let's just get these videos uploaded. Attended with a son. This patient has Parkinson's, and the only reason why I'm making reference to that is, so with Parkinson's, sometimes they get Parkinson's patients get unsteady hands, but the patient also had a bit of unsteady head, so I just had to be very cautious when I was doing this procedure. I just didn't want the patient to make any sudden head movement. So when I'm inside the ear with the instrument, and obviously this wax is quite deep, it is impacted, I've got one eye on the patient, in essence, just keep an eye on them, and I'm constantly at the ready to remove the suction probe if need be. So it's a very tentative procedure. I'm not sure, it's the first time I've watched it back, so I'm not sure if it shows when you watch the video itself, but I'm always just ready to quickly pull out the suction probe if the patient makes any sudden head movements. So you can see a bit of the tympanic membrane posteriorly. Patient had been using drops, so that definitely helped. And again, the view is just so unbelievable. You just don't get this view with a microscope or head loops. You can see the whole ear canal, you can see the whole circumference of the tympanic membrane in a moment when we remove the wax. So the procedure's done really, occlusion's been resolved, just some soft wax around the edge, so it's just gently, quickly, just trying to go in. Patient was quite steady, so, but again, I'm just being very cautious, ready to move, and for me that was it. I don't want to do any more. In real terms, even if the patient didn't have Parkinson's, I would have left that wax on the anterior canal wall. It's so insignificant. A bit of wax is good for you, and I'm going to upload a presentation in the next week or so that I performed for some GPs locally, talking about earwax, the benefits of earwax actually. Earwax does have a health benefit, so I will kind of try and upload that presentation and I'll do a talk over. Same patient, just the left ear again, just want to remove this wax as quickly as possible, as safely as possible. I had a bit of a narrow ear canal entrance, you can see there, but I'm able to enter the ear, stretch the ear open with the Zollner suction probe, which grants me access to the ear canal, just a bit at the base of the ear canal quite immediately. So I'm just re-entering, just very quickly hovering over. You can see the endoscope's not even in the ear, it's just literally on the outside. Nice and healthy eardrum. And there's the remnants of the wax. So the wax was quite sticky and wet, so I was able to take an image. And last but not least, this is the third client. So this client had used a smart swab. It's one of those kind of spirally devices that I've seen on Amazon and on Facebook. It's like a corkscrew, and they just push the wax further in the ear. It's really impacted on the eardrum. I think they also caused some bruising to the ear canal. You will see that a bit later on the anterior canal wall. So the patient had been using drops as well, but it's very impacted. It's lodged in the isthmus, so there's a narrowing about 0.5 centimetre away from the eardrum, where the ear canal narrows and then it protrudes outwards. So the wax got lodged. Just bringing that forwards. There we are. I've got the big plug of wax out. It's instant relief for the patient. It's a bit of dead keratin there. So the eardrum, the symptoms were alleviated, but you can see it's a bit of mushy dead wax with some keratin. So I've just gone back in with the Zollner suction probe, just trying to see if I can mop it up. If by me trying to remove this wax is becoming a bit uncomfortable for the patient because we had to possibly come in contact with the canal wall, I would have just left it because the symptoms are alleviated. But the patient was okay, so I've just attached a fine end gauge now, so I'm just approaching the eardrum. So it's just some dead keratin, sticky wax posteriorly, just going to be really delicate. The eardrum is about 1 millimetre in thickness, so the last thing we want to do is perforate it. So I'm just hovering over, really, kissing the surface. So that wax didn't peel, so I've left it, and there's just a bit more anteriorly. So there's the bruising on the side of the ear canal wall that I made reference to earlier. It's just some soft wax anteriorly. You can see the view that we got. It's just an amazing view with an endoscope. And that's it. The handle of malleus, so the hammer bone is fully visible now. Eardrum's clear enough. I hope you enjoyed that video, guys. I'll try and upload some more during the week. If you're watching on YouTube for the first time,